Yeah, it's the ODA this week. So it's, I don't know, it kind of feels surreal, when you see the pictures of us, like the memories coming up from 3 years ago, 5 years ago. And now we're virtual on doing our presentations. And yeah, I miss seeing everybody for sure. I mean, we all do, right? It's
Right. Well, in ODA is usually where you go around and make sure you check in with everybody. It's your once a year to make sure you get around to see everybody who's there, and you're texting going, where are you?
yeah. Oops.
It's just not the same. I love the virtual, and I love that we have moved our show honestly online, because we can reach so many more people. People can watch it now later and going on Facebook, but there is something to be said about the connections that we've all made from actually walking the floor and seeing each other. And when you're at the exhibits and you can physically touch the instruments and you can feel them, it just is different. But I'm glad that they've figured out a way to pivot as well, because I think it's so important to bring this education to everybody.
Yeah, and they've done it well.
Yeah.
Pivot.
Absolutely.
Yeah.
Well, we're at 12 o'clock here. So we've got the majority of those joining us are here, either through Zoom or through our Facebook page. So welcome to everyone. Just before we get started, I'm going to be sort of in the background here with any questions or comments that come in. We have a lot to get through today. We're very excited. So if you ask a question, most likely we'll probably wait until the end and then bring up any questions that come in from the audience. So feel free to use that Q&A at the bottom of your screen to ask us any questions. And the same with those joining from Facebook. If you want to add a comment in there, I will bring that up towards the end of the program. Kathleen, I'm going to hand it over to you. And if you wouldn't mind just sharing with everyone how they obtain their CE certificate for today, that would be wonderful.
Okay, so to obtain your CE, if you are an RDHQ member, I was going to say manual, if you are a member, it'll be in your portal. So it's members.rdhu.ca. It'll be in there. We're going to upload this session and put the certificate, the questions in there. We also always put it in our general portal. So you go to rdhu.ca and you could go to view webinars and you would find that portal. We also send out an email on the Monday after. So we'll send out an email with click here to access. So if you are on with RDHU, if you're a member, you'll get that email on Monday. If you're new to RDHU and you're watching through Facebook, we welcome you to join our community. And you would go to www.rdhu.ca and fill out the web form, your name, your email, and your province, because we send out weekly communication, and our language is a little bit different for Ontario dental hygienists than for everybody else across Canada and in the US. Okay, so yeah, so that's how you do it. I hope I answered that clearly. And you can always email info@rdhu.ca as well, and simply say, I would like to get my certificate, and then we'll send you the link. Okay. All right. So with that, I would like to introduce our lovely guests today. Okay. So we have Dr. Viviano, who has obtained his credentials from the University of Toronto in 1983. His clinic is limited to managing sleep-disordered breathing and sleep-related bruxism. He is a credentialed diplomat of the American Board of Dental Sleep Medicine and has lectured internationally, conducted original research, and authored original articles on the management of sleep-disordered breathing. His clinic is the first Canadian facility accredited by the American Academy of Dental Sleep Medicine, and he is the clinical director of the Sleep Disorders Dentistry Research and Learning Center. Dr. Viviano also hosts the Sleep Disorders Dentistry LinkedIn discussion group, conducts dental sleep medicine CE programs for various levels of experience, including a 4-day mini residency, and administers the sddacademy.com online learning platform. All right, and then we have the lovely Elaine Steckel, who is a clinical manager, team instructor, and chairside assistant. Elaine obtained her honors CDA diploma from the Toronto School of Business in 1990 and her PDA certification in CDA Level 2. MBDE certification from University of Western Ontario in 1992. She first joined Dr. Viviano's general dental practice in 1994 as a chairside assistant and clinical administrator. Elaine participated heavily in the integration of sleep disorders dentistry into Dr. Viviano's practice at that time and for the following 10 years. Following which she has obtained experience in the pharmaceutical research development industries. Elaine is currently enrolled part-time at McMaster University, where she's completing a diploma in marketing. And if you haven't followed, you have to follow at Sleep Disorders Dentistry's Instagram, because you'll see some of this marketing skills coming out there. So Elaine's passionate about both nutrition and health and is a valuable team member. So thank you so much for being here today. We're really excited for today. I just thought I would start off by reading. I wrote an article, and it was just published last month with the Oral Hygiene, and that's with the Oral Health Group. So I just thought I would start by introducing the subject. And I have the obstructive sleep apnea, OSA, is a disorder characterized by upper airway collapse during sleep. OSA is one of the most prevalent sleep disorders and is potentially fatal, affecting 4 to 9% of the adult population. Like most sleep disorders, OSA is unrecognized, underdiagnosed, and undertreated, with an estimated 70 to 90% of cases going undiagnosed. Dental hygienists are the first line of defense in recognizing and screening for potential OSA. We play a critical role in improving the quality and longevity of life of our clients. Understanding the sleep disorder, how it affects our clients, how to screen for potential OSA, and recognize when to refer is in our area of influence. So my interest in sleep apnea began because of my own personal journey. In spring 2019, I was diagnosed with severe sleep apnea, and I stopped breathing 55 times an hour. So with that, I am really excited to have you both here as our guests and to start the conversation. So I thought we could start with by asking Dr. Viviano, what got you interested in specializing in sleep dentistry?
Good day, and thanks for having us here today. This is circa 1996, 97, Tuesday evening. I'm working alongside 4 hygienists, and it's a busy evening, and I've got a syringe in my hand because I'm waiting for the patient to stop talking so I can freeze her mandible so I can get her 3/7 MODVL done. But she wouldn't stop talking, and she kept on talking and talking about her husband snoring and how much it was interfering with their relationship, and she was thinking of getting a divorce. And my level of interest was 0. All I could think is, can you please stop talking so I can freeze you up, go do my hygiene checks, get back in here, and do your filling. I'm a dentist. That's what you came here for. I'm not your therapist, right? This was my level of interest. On that same week, that Friday, I was at a cosmetic dentistry course because I'm a dentist. And that's what we do. We make teeth look pretty and function well and so forth. And in the distance, I could see over one of the vendor tables, big block, bold letters, snoring. And I walked up to the booth. It was a dental services group lab table. And I asked someone that I met for the first time that day, Joanne Friedman, what can we do for snoring? And she showed me a couple of appliances, handed me a couple of papers that had just been published the year before, and then went on to talk to other people. I went back, sat down, read, went home, spent the rest of the weekend on the internet, reading as much as I could find. I was just blown away by the impact we could have on our patients' lives and how impactful snoring and sleep apnea in particular is to someone's health, and how we could help manage that. And by Monday, I showed up at the office with little trifold folded flyers advertising a 1-hour evening course for our patients. It's how we could help them with their snoring and sleep apnea. So that's how quickly things happened for me. I mean, I became so passionate about it overnight. And I haven't stopped learning about it or speaking about it since. And Louise, I think, was working at the office at that time, so she can attest to how quickly that passion came on. And I know Elaine was there at that time as well. So that's how it happened for me. And it's interesting because when I teach my CE courses to newbies, I look for that aha moment in their eyes when they're listening to how impactful we can be in our patients' lives. And it's really gratifying to me because I know exactly what they're experiencing, because that's what I went through that Friday.
Wonderful. Thank you for that. And just based on what you were just saying, how you kind of had that aha moment and you started to see sort of the opportunity we have to have an impact on our patients or our clients. Could you talk about some of the things? So what do dental offices have to offer in the way of sleep apnea to their patients?
Well, first off, I think maybe we'll let Elaine start off on that a bit, and then I'll join in. And
Sure. Yeah, great question. What we have to offer, there's a few things, there's many things that we can offer, how to get involved. Like Dr. Viviano said, pamphlets, posters are very effective into drawing the patient's attentions by learning as providers, as hygienists. I'm not really sure if we realize that we all are influencers, very powerful influencers. And when you have your patient in that supine position and you're going over to their medical history, are we screening for them? Screening is such an important part. Asking them, if you anatomically a patient who's laying down and you don't see that airway, it's probably appropriate that you screen that patient. 1 in 4 adult patients are apnea sufferers. We know that, and by us getting the knowledge and informing so that we can pass on that information to our patients, I think it's one of the most powerful things that we can do that will set us apart. Also, once you identify these patients, referring to their family physician so that they can get the help that they need, and at their recare appointment, follow up to see if they actually went to their family physician and had that taken care of. For the dentists who like to actually get involved into the process of making the appliances, there's numerous resources that the time is too short, but you can actually visit our website where they can get a wealth of information, free information on how to get started on helping their patients, and they're providing them an opportunity to have a better life, a better quality of life. Now we understand that sleep is so important, that when you are suffering from waking up and not having that nutritious sleep, it affects every area of your life. So now we have that opportunity to provide that information and to be that link to influence our patients in such a positive way.
Thanks, Elaine. So the ADA, American Dental Association, published guidance on the role of dentistry in sleep disordered breathing just a few years ago. And it's still not being done universally, but what they're saying is that we should be increasing awareness in the dental office for our patients. So, there's a lot of people walking around that have sleep apnea undiagnosed, not aware that they're suffering from sleep apnea. So awareness campaigns, as Elaine alluded to, with the way of posters or pamphlets and so forth, go a long way. Then starting that conversation when maybe you see some of the clinical signs and symptoms associated with the sleep apnea, looking and seeing a narrow airway. As dentists, And as a hygienist, we never really look beyond the teeth. So this requires taking a look down the airway and see what's going on there. Does it look really crowded? Do the tonsils look big? You know, is the tongue so high that you can't even see the uvula? You know, it's a matter of us becoming more aware of what to look for. Then we can make them aware. And as Elaine mentioned, 1 in 4 of our adult patients have a sleep apnea. So 1 in every 4 of your regular recare patients that you're seeing that are adults could warrant some level of conversation, that could warrant some level of referral. That's the frequency at which it could be happening if your eyes were open and we made the patient aware of the issue. So these people are coming in and leaving our office never having that conversation. But don't feel bad, because they go into their primary care physicians and leave that office and the conversation's not happening there as well.
No.
Exactly.
Right? So, you know, think about this as a medical disorder, but we can have a profound impact now that we participate in its care and management. And also we can participate in the uncovering and the screening and get the patients into the care that they're looking for.
Yeah, it's a simple asking. Oh, sorry. I was going to say it's the simple, you know, doing that assessment, but also asking the questions like, and do you snore? Are you choking and gasping for air at night? Do you wake up feeling exhausted and not refreshed? Do you have a fogged brain? Like all these things, like no one ever asked me any questions. The physician, other dental professionals, it just was never the conversation. So that's why when I found this out, I was like, oh my gosh, and here I am in the field that I really became passionate about, you know, the education part of it, the bringing this awareness to dental hygienists that aren't assessing.
So Dr. Viviano, if you could give us 3 questions that we could add to our review medical history that we're doing with them at every appointment, what 3 questions would reveal to us that we should talk further in this area?
Well, one question would be, have you ever been diagnosed with sleep apnea? Because there's a lot of folks, well, 50% at least, and probably more, that have been diagnosed with sleep apnea that remain untreated and unmanaged. And unfortunately, no one's bothered to mention to them that there are other alternatives aside from the gold standard care of Cpap. So those people are falling through the cracks. So by asking that question, you will uncover those patients. Then basically asking, so do you wake up feeling refreshed in the morning after your sleep every day? Because if you are sleeping normally, you should be waking up ready to go, energetic, passionate, ready for the day. If you're not, then there's something going on when you're sleeping. Okay. And of course, do you snore? Because 95% of apneics snore. Not all apneics snore, but with 95% of them snoring, right? And probably almost all of them, I'm going to say 99% of them expressing tiredness. By asking those 2 questions, you're going to uncover pretty well everyone that you need to speak to.
I think this is something that people they brush over. We take the time, we're so busy as a hygienist to like clean their teeth. And, you know, we have to take the time to screen our patients because people are dying, people are undiagnosed. And we do always focus, I feel like people will ask, you know, do you have sleep apnea? But we don't often explore or expand on the snoring aspect. And I think snoring is not something that people take seriously. Oh, it's just a little snore, my kids snore. Well, there's a lot about snoring, and maybe you can give us some information or statistics on that too.
Well, I mean, snoring, if you're talking statistics of prevalence, 40% of 40-year-old males snore, and it goes up by about 10% each decade. So 50% of 50-year-olds, 60% of 60-year-olds, and that's a conservative. Now, females, it's considerably less than that until menopause. So between the age of 50 and 60, you catch up to the males. That's just the way. So, you know, that's the prevalence.
One more thing.
Yeah, I'm sorry, Nate?
One more thing that we have to worry about.
So, but that's the prevalence. So you know that probably 1 in 2 of your patients snore. I'm talking your adult patients,
Yeah.
right? And with regards to the children, children shouldn't be snoring. It's not cute. Like they're always not cute. Look at listen to the little snore. They're snoring. That means their airway is straining to get air in. Things are fluttering around. Things are narrowing down, and they're being deprived of oxygen. Now they're being deprived of oxygen at a time when their brain is developing, their bodies are growing and developing. This is not good. Now it's interesting. Studies have shown that ADHD is more diagnosed now than it used to be. And tonsillectomies don't happen anywhere as often now as it used to be. It's almost an inverse, as a matter of fact, it is pretty well an inverse relationship. With the reduction in tonsillectomies, there's been more and more ADHD. And there's what happens is if somebody is sleep deprived, they have ADHD like characteristics that they're demonstrating. So there's a lot of misdiagnosis that way. Well, let's drug them up. Let's just give them this medication and help them manage it rather than managing the source of the problem. So there is a lot that we can do in helping our children getting the appropriate. Now there's resistance sometimes on the medical side. I've encouraged a hygienist to talk to their patients about this, and their patient's physician said, tell the dentist to stick to dentistry, right? So, there's, and so discouraging the mom from having them look into the tonsils, or even making that referral to send them off to have the tonsils looked into, because they have become very conservative with regards to abdominal tonsillectomies. And the reason is because there are comorbidities associated with that procedure. So you don't want to be just doing it haphazard. I get that, but the pendulum has swung too far the other way. So finding some type of balance when it is appropriate, it is the most common procedure that's done to help our children breathe better, right? So the snoring is not only with the adults, but also with regards to our pedo patients.
So, Dr. Viviano, I know that you said that a lot of people are diagnosed, which I would concur, but they are non-compliant with the Cpap because they have been told that that's the best therapy, but then they're non-compliant because it's uncomfortable. Some people are put it on so tight it actually moves their teeth. So can you speak to the whole Cpap thing and what the other alternatives are? Because of course I know, but we need to share that.
Right. So Cpap is being considered gold standard ever since it was first introduced circa 1980-81. And, I can understand that completely, because prior to Cpap, the only therapy they had to offer was a tracheostomy. So, you stop breathing 30 times a night, we're gonna just punch a hole in your throat, give you a little plug to wear during the day. At nighttime, you take it out, you're gonna breathe from your neck, you'll sleep like a baby. So you can imagine how many people said, like, you know what, I'm gonna check my day timer and get back to you, right? Okay, so the bottom line is Cpap comes along and they can split that airway open. They use pressurized air. They're just blowing air up the nose, down the airway, pressurizing the airway, stopping it from collapsing. 99+% of the time, they can stop the airway from collapsing. So this is great. You know how many things in medicine work pretty well 100% of the time? Basically zero. It's a very uncommon event. They have an amazing therapy there. Problem with it is compliance, adherence. 6 months, about 50% are still compliant. And get this, at 5 years, about 17% are still compliant. Well, what's happening with the other patients? They're dropping off, and nobody's bothering to even talk to them about an alternative therapy. Now, of course, we all know on the panel here that there's oral appliances that are available to manage sleep apnea. Do they always reduce the apnea completely like Cpap does? No, they have a success rate. However, the other thing they have is a very good adherence rate. 90% of patients that get an oral appliance will continue to wear it long-term. And typically when they wear an oral appliance, the nightly use is like something like 7.5 to 8.5 hours. Whereas studies with Cpap show, first of all, they consider 4 hours a night to be compliant. That's how low they set the standard. to determine that you're compliant. But typically compliance is around 5 and change on the average. So you get some people wearing it 3-4 hours a night and some people wearing it all night long. But overall, the number of people that are actually wearing it at all drops to 50% at 6 months and 17% at 5 years. So that sort of sums up the situation there. Now, when we look at oral appliances, maybe 8 to 10% of patients are taken care of with an oral appliance. Okay, so what's happening to all the other patients? They're not getting surgeries. There really, in Canada anyway, there really isn't a good alternative surgery that isn't invasive like maxillomandibular advancement, right? That will work to about the same type of success rate as oral appliance therapy, does about the same thing. But, people aren't lining up to have that procedure done, especially if it's like mild to moderate sleep apnea. So there aren't really good surgical, interventions. In the States, you have a hypoglossal nerve stimulation, which has a pretty good success rate, but unfortunately, there's not much of that happening in Canada because of the cost and the lack of insurance reimbursement. So these are the conservative therapies we have: CPAP and oral appliance therapy. Yeah. Now, the thing to keep in mind about oral appliances is that the mean disease alleviation associated with oral appliance therapy is similar to CPAP. When they look at measurements of health outcomes, of relief of hypertension, reduction in cardiovascular strokes and heart attacks and events, vigilance testing like driver simulation, measurements of sleepiness, pretty well right across the board. Oral appliances and CPAP score similar, even though CPAP is more effective at reducing apnea. And they feel that the explanation for that is the fact that patients are wearing their oral appliance all night long makes up for the fact that it may not be getting the apnea all the way down. Yeah.
So what are some of the side effects with wearing the oral appliance?
Well, the truth is an oral appliance is if all goes smoothly, an oral appliance is a very benign experience, because you would never place the appliance in the mouth that holds a jaw in a position that would interfere with them falling asleep. So those are the words I use. Okay, I place the appliance and I ask them, close your eyes. Do you feel that you could initiate sleep with your jaw in that position? If the answer is no, well then I put the jaw further back. So they're never going to be sent home in a position that's uncomfortable. The issues that come about are what happens once they fall asleep. We all know grinders and what they do, and they're going to be fighting the appliance at first, and that this varies greatly from patient to patient. So you're going to get variable levels of symptoms or signs that something's different the night after wearing the appliance when you first get it. Okay, what you're doing is you're fighting the appliance. You're going to do what you are accustomed to doing, that type of movement, the type of grinding you're accustomed to doing. What happens is your brain catches on with time that you can't do this. There's things in the way here stopping you from doing it. You establish new patterns of behavior and movement where the appliance allows you to be. And once that modification happens, all of those pains and aches go away completely. Okay, so it's not the appliance that causes them, it's the activity. And once the activity changes, it's done. Okay, so what I would use as a comparison, if you went to the gym with your friends and you were working out, you were committed to getting really fit, and you were showing off a bit, you'd be a little bit sore and stiff the next day. Well, this is what you're going to feel after wearing an appliance at first, because you're doing resistance exercises up against the appliance with your facial muscles. Okay, but it's all benign and it'll all go away and you're not permanently damaging anything. There is no evidence in the literature whatsoever that it leads to long-term temporomandibular dysfunction. Okay, although that's a myth that is often propagated. And the only one long-term consequence that is well established in the literature is bite changes. Okay, so it will influence your bite. For some patients, the bite change is actually favorable. And for other patients, it may be less favorable. So they have to determine and decide whether that's what they want. Now, as Louise pointed out, Cpap will also lead to bite changes. So it's not like the other conservative therapy doesn't also lead to bite changes. Okay. Now, I need to point this out because this is very important. I hear often, my dentist or the dentist I work with, or put an appliance in, and it was creating all these temporomandibular joint dysfunction and pain for the patient, and they stopped wearing the appliance. But that may be their brother-in-law or whatever, that had that experience. And the issue is this: if an appliance is well placed and balanced, it does not lead to any of this. So when this happens, it's a mismanagement of the case. And unfortunately, there's too many dentists that have taken an evening program and treating it like a regular night guard and just throwing it in, and not aware of the rules of engagement that lead to these types of mismanagements. And in my view, that is doing harm, because if you have not taken the time to learn how to do this properly, and you've mismanaged that case, and they dismiss an oral appliance as an option, and they can't tolerate Cpap, you're responsible for shortening that individual's life and reducing their quality of life, right? If an appliance doesn't get the apnea all the way down, but it is optimally calibrated, you've done nothing wrong. You've done a good job. Now you could look at other adjunctive therapies to help get them the rest of the way. But if you have mismanaged the placement of that appliance because you never took the time to learn how to do it properly, you have done something wrong.
Right.
So can you review some more of the oral side effects? We talked about occlusion. Are there any other oral side effects that we should be aware of? Or oral appliance side effects, I guess you should say?
Yeah, the only other one that I forgot to mention that I can think of is you put something in your mouth, your brain thinks you're about to start eating. So what do? You salivate. So there'd be a little bit of drooling at first. We notice this when we put ortho appliances in, when we put grinding appliances in, is the same type of thing. Then the next step after that would be, from the initial power struggle, a little bit of aches and pains in the joint, muscles, ligament. And then beyond that, it settles down and it's a very benign thing. So you wear the appliance, your jaw forward all night long in the appliance. So once you take it out, you stretch things out in the morning, you reclaim your bite and you go on with your day. Long-term bite changes. And that really about sums it up.
There's not a whole lot of, in when I'm dealing with clients that have been to see Dr. Viviano, when they come back and they're instituting their wearing of an appliance, they're so happy that this is so portable and so manageable on a personal level than trucking around their equipment on vacation.
At the airport.
Yeah, yeah, exactly. That's where I was going. And the compliance rate is these days, because so many people wear night guards, is so effective and efficient, this therapy. So, and I'll have to say that I have little labels with Dr. Viviano's website on it that I can stick on a bag that they're taking home with their stuff on it for them to go and read, because there's some great papers and really good information, and let them know that there is further help out there than what they're not complying with. So that is
A good idea, Anna Louise.
Thank you. This is wonderful.
So
That is a great idea. To send them home with that, and not just tell them, because they're going to leave and forget too, right?
That's it. They need that link, and then they need to go and read, because if they go and they read and they come to Dr. Viviano and Elaine with more knowledge, then they know the right questions to ask. And so maybe both of you, Dr. Viviano, maybe you could make it, if we wanted to refer one of our clients, maybe they're non-compliant with their Cpap, or they want to look at other options, what type of information could we send to you maybe ahead of time, maybe to Elaine by email? What type of information would be of use to you, and how could we do that?
So a referral to our practice is very simple. What happens typically is the patient connects with Callie over the phone, and then Callie will review the following with them. You know, because these are not my patients that I'm seeing, they have other general dentists. I would like to have a copy of the most recent radiographs that are available. So that way we don't have to unnecessarily take radiographs, right? Then we need a copy of the sleep study, the most recent sleep study that they've had. Baseline sleep study, not the Cpap sleep study. And then if there is a physician in a loop with a sleep study and so forth, and they are open to an oral appliance, then having a copy of a prescription for an oral appliance, because the dentist can't proceed with an oral appliance without a prescription, right? So those are the important documents, and Callie reviews that, and usually we have all of those things, or almost always we have all of those things at the time of the consultation.
Perfect.
So we should refer to the GP first, right? And then the GP refers them to the sleep test,
So let me
right?
explain.
Sleep clinic.
Let me explain. So there's two streams of patients. So there's the diagnosed patients, which can be referred directly to me, right? They've already been diagnosed. They've had a sleep study, and we can request all of that information, and Callie can help facilitate requesting that information from the sleep specialist, right? Then there's the undiagnosed. Those could be referred directly to me if they just want to come and find out more, but really it's more efficient use of their time if they're sent to their family physician to arrange a referral to a sleep specialist so that they can have a sleep study and get a proper diagnosis. Right. So the diagnosed patients are treated differently than the undiagnosed patients. Right. It's more efficient use of their time. I can't refer to a sleep specialist. No, it has to be another physician, because that's just the way it works in Ontario. So they go through their family physician to get to the sleep specialist, have a sleep study, get a diagnosis. Now, of course, you know, Cpap is going to be most often going to be pushed as you know, first line therapy, which it is. And if the patient wishes to try that, that's fine. I mean, there's nothing, you know, Cpap works, and it is good if you can tolerate wearing it. The caution I'll put out there is if you have the option to trial a Cpap rather than outright accepting it, then this will work in your favor. And it's an important reason. The reason is that if you accept it outright, and say you're in Ontario, or HIP pays for a portion of it, and your extended health insurance will cover the rest, copay, and cover that off, and it's nothing out of pocket. So far, it's great news for the patient. And if they can tolerate wearing Cpap, that's fantastic. But unfortunately, we know the statistics. We know that a good number of these patients are going to end up putting the Cpap unit in their closet. So now they're interested in looking into an oral appliance. Well, because they're extended healthcare, their private insurance made the co-payment on the Cpap, they've lost any opportunity to have coverage for an oral appliance. So if you're being recommended a Cpap unit, what I recommend to patients is that they take a trial of it, right? They take a trial and they establish that they can actually tolerate wearing it before they accept it. And that's routine, that's available. It's just not always offered, but if you request it, it's always available. So now the patient can trial it, and if they can successfully tolerate wearing it, great. They can proceed with it, and they're wearing Cpap, they're managed. They don't need to look any further. If they cannot tolerate wearing it, they were able to establish that, give it back, and they did not lose the possibility of having coverage for an oral appliance from their extended healthcare plan.
And it's the extended insurance. It's not the dental.
No, it's not dental. It's their medical extended healthcare. Yeah.
A lot of patients, they will actually get very discouraged because there's not even a code for it, because we're not correcting a dental problem. It's a medical.
Interestingly, there are codes in the ODA fee guide for oral appliances, but they're absolutely useless to us, because if you use them and submit it to the dental, they'll just be denied. So when we submit them to the extended healthcare, we don't even use those codes. The only reason you would use those codes is just for internal documentation on your computer system or whatever.
it's considered a durable medical device. So
Right.
Yeah, and that's great if you can find a clinic that does do the trial, because otherwise, yeah, that would be hard for someone to switch over after not being able to do the CPAP and then having to put the money out for the appliance.
For the appliance, yeah.
So realize that all of the CPAP vendors are in a position to do the trial. It is a standard that they all do. It's not always mentioned to the patient. They're happy to just sort of like, get the CPAP out the door. Now you've committed to the CPAP, but you don't know yourself as the patient that you've just lost any opportunity to have access to oral appliance therapy. And it only really comes to light until after the fact when it's too late. And the insurance says, well, you took the CPAP, you don't qualify for an oral appliance for 5 years. That's when you find out.
Especially because they have all the different types of masks, right? So like the one that I have, here I am on, like, my sister, she has it, and she would kill me if I share that, but she doesn't want anyone to know she has it. And I'm like, I share that I have it. But anyway, the one that I have is just like a little pillow under the nose, right? And so they had me try different ones on there and said, this is the most popular. And then away I went, but they didn't offer a trial. And there's this app that I'm very much an app tracker. So the app tracks how many hours I was wearing it every night. So I didn't want to, even if I was lying there awake for 5 hours in the night, I would keep it on because I didn't want to wreck my streak. So if you have someone who's like, a tracker, the app does help. I didn't want to lose, I got my silver streak and then I got my gold badge. And
Oh my God.
yeah.
Tell me you're a tracker without telling me you're a tracker.
Exactly. I am.
These wearables can be very useful in helping patients become more aware of their sleep habits and how long they're sleeping and so forth. But they can give a lot of misinformation as well. Because they're just not as accurate as having an actual sleep study.
Could someone have the CPAP and an oral appliance? So if you were traveling, could you just bring your oral appliance for travel and leave your CPAP at home?
Yes. Interestingly, oftentimes what I'll have happen is somebody come to get an oral appliance so they could use it for travel, and it ends up replacing their CPAP altogether because it's just so much more convenient to use the oral appliance alone. And once we've documented and demonstrated that the oral appliance is doing the job, they let the CPAP go. Not that they couldn't tolerate the CPAP. So the other thing too that's important to note is that for some patients, if their problem is serious enough and they can't tolerate their CPAP because the pressure is too high, and an appliance alone doesn't manage their problem adequately, so they have residual apnea. By marrying the two devices together and wearing your CPAP and your appliance, now with the appliance doing part of the job, the pressure is much lower. Now they can tolerate wearing their CPAP. So it's like a combination therapy.
Hybrid.
Right. For those patients that have a serious enough problem that that happens, you can marry the two together and successfully manage them.
Yeah.
That's and then so if the pressure is less, is their tissue in better shape as well? And does the appliance also help keep their tissue in better shape, like holding the moisture on?
I don't believe it would have anything to do with holding the moisture on, but would you say the tissue in better shape? You mean the tissue of the airway?
No, because like their oral mucosa ends up looking dry and battered, right?
So it's dry and battered because of the air flowing through the mouth and the vibration of the tissue and all the inflammation that happens there. Right. So when things heal up is because that activity is not happening anymore. It's not fluttering around and bouncing off of each other anymore. Right. And if now that's not happening, plus hopefully they're nasally breathing, because we want all our patients to breathe nasally. If you have any patients that don't breathe through their nose that are mouth breathers, not only does it play a role in we know what it happens to the soft tissue and dentition, but it also compromises their sleep. And so they need to get to an ENT to see what they need to do to resolve that issue. Because even if it doesn't improve their sleep apnea, it will definitely improve their quality of sleep, and they'll wake up feeling more refreshed if they're nasally breathing, right?
So where I was going with that was like, if it's a hybrid situation, then because there's less pressure now because it's in a hybrid, right? Then maybe their oral environment would be in better shape.
Yeah, well, when you've got the CPAP on, it's traveling up through your sinus, down your airway, but not really coming out your mouth.
Right.
Right. Otherwise, if it's coming out your mouth, the CPAP's leaking. Right.
Yeah.
So I think most of it has to do with just a reduction in inflammation because the soft tissue is not battering around.
Yeah. Okay.
Anymore. That would probably be the biggest contribution.
Well, this has certainly been an enlightening session today. And I really feel that, you know, while I have been asking and dealing with some of my clients, I'm going to be more intentional starting Monday.
And also the follow-up. So now that they've been diagnosed, now what, right? And then at their next appointment, you ask them, because then I learned so much from Dr. Viviano about sleep apnea that encouraged me to keep up with treatment, because I knew the consequences, and but they don't know. So we have to educate them on the consequences if they don't follow through with treatment. Right. So sharing that information, following up with them, putting a protocol in your practice so that you're on the same page. All that is so important. We have a question about, what do you do with somebody they snore a lot and they've been sent off for a test, but they came back not having sleep apnea. And my brother is the same. And I've seen it happen. Like, he stops breathing, and he's gone twice, and they came back and said that he doesn't have it. We're all like, wow.
So on the spectrum of disease, there's snoring, then there's something called upper airway resistance syndrome, where the airway is narrowing down and it's straining to breathe. So as a result, they're being aroused out of deeper sleep into lighter sleep. So their sleep is disturbed. These are tired snorers. That's called upper airway resistance syndrome. And then it gets into the hypopneas and apneas, where it's full or more closure with blood oxygen desaturation, and you have a sleep apnea going on. So that's sort of like the spectrum of disease. So when sometimes patients present with upper airway resistance syndrome, you've got some sleep specialists taking it serious and suggesting that and suggesting treatment. It's sort of that never land, where compensation drives behavior. The world is insurance driven. Insurance companies don't consider upper airway resistance syndrome to be something worthy of. They don't even want to treat mild sleep apnea in many cases, up to 15 events per hour. Never mind, now you're pre-sleep apnea, you're not even into the sleep apnea category. So it depends on the sleep physician you go to how that's going to be treated. So it may be that type of situation where they went and they were told, well, you just snore. But really, if they're tired, then that requires some type of treatment. The problem with the sleep specialists is that, unfortunately, many of them don't take an oral appliance seriously. And what they do is they say, well, you're just a snorer. You're not going to wear your Cpap for just snoring, and you're a little tired. So they don't really feel they have something to offer, unless you have actually outright, serious, sleep apnea or some numbers to take care of. Because if you wear the CPAP and you had 15 or 18 events per hour, we know we can get that down, right? And when you've got upper airway resistance syndrome, although that can be demonstrated, the insurance company doesn't cover for that. So you're in never land there, right? However, an oral appliance can be recommended, and that does work for all of those categories as well. But once again, you do need a prescription from the physician to make the oral appliance. What's going to happen, though, if in the absence of a sleep study documenting sleep apnea, is unlikely that you'll get insurance coverage for it. So if you do qualify for insurance coverage, you need to have a positive test, a sleep study documented sleep apnea. Typically, there are exceptions. There are exceptions when people have discretionary health spending accounts in their insurance. There are exceptions, but most of the time that applies.
Dr. Viviano, this is obviously a topic that is of interest to many. There are a lot of questions coming in. If it's okay with you, maybe we'll just take up a couple of them, and then Kathleen, maybe we can direct them to some additional resources if we don't get a chance to get to all the questions here.
We're happy to answer questions.
Okay.
Even if they direct it to us, we can provide you guys with our email address, and we'll be more than happy than if they,
That would be
contact us
wonderful.
directly. We can address that.
Okay, perfect.
Sure.
If you don't mind sharing the contact information, because I have a feeling we'll be able to get to all of these questions.
Sure, absolutely, yes.
Okay, wonderful.
Absolutely. At the end, I can probably, and
Wonderful.
and we'll be more than happy to.
It's really simple. It's Elaine at drviviano.com or John
John
at
at
Dr. Viviano.
Viviano.
Okay.
Can't get more simple than that.
Yeah.
Maybe I'll ask a couple of the questions that are kind of
There's lots.
Yeah.
Okay, so let me see here. Can you explain the connection between the sleep apnea and the sleep bruxism a little bit? Someone was just asking about why the two are related.
Right, so there's two types of bruxism. There's idiopathic bruxism that's centrally mediated, where the brain is sending that signal to brux. And to this day, to this moment, we don't really know why it happens. There's all sorts of theories, but they've never been able to actually prove exactly why it happens. They just know that it happens. Then there's actually a sleep movement disorder bruxism that's related to the airway event. And once again, they don't know exactly how it's related or what causes what or why, but they know they're related. So you have two types of bruxism happening in a patient typically. They're idiopathic bruxism and the bruxism that's layered on top of it that's coming from the airway issue. If you manage the airway issue, and it doesn't matter if you use Cpap or if you use an oral appliance, if the airway apneic events go away, that bruxism will go away, the movement disorder that's associated with the airway. Okay, so this is where somebody that has upper airway resistance syndrome or just mild sleep apnea and they're tired, they're bruxing their teeth from those airway issues that are happening. Once they wear an appliance, not only are they less tired, but their bruxism is going to be reduced as well.
Great answer. Thank you very much. Somebody was asking about sort of the online products for snoring that are available, and just wondering if things like that might actually be contributing to tooth mobility.
Well, a well-made appliance is going to take into consideration, stability of the dentition. And of course, a poorly made appliance is going to do, it's not going to do that, right? So clearly, if you're using something over the internet, that's meant to fit everyone's mouth, you're at risk of using something that could be, cause more tooth movement. There's no question. But not only that, you're at risk of using something that could be helping you suboptimally. It could turn you from a snoring apneic into a non-snoring apneic. So in other words, you spend $100 and you buy this on the internet, you fit it in your mouth, you boil and bite it, fit it in your mouth, and now you're not snoring and you think you're managed. But meanwhile, you may still have some meaningful apnea going on, right? And you're still medically compromised, but you think you've managed yourself. So there's a real danger in taking the do-it-yourself approach to this. And that's not self-serving, it's actually real. They've done research on this and studies to demonstrate the difference. There's a night and day difference between outcomes associated with your typical over-the-counter device compared to a custom-made appliance.
Mm-hmm.
Just to add to that, Dr. Viviano, I just wanted to add, and also there will be side effects. Like people were asking about side effects, right? Like who knows what side effects other side effects that will actually entail using something over the counter. With our protocols, it's not that we just give you the oral appliance, it's a whole treatment. It's a whole journey that the clients go with us together, a journey of wellness. So it's not just taking a scan, taking an impression, and here you go, here's the appliance. is not like that. And this is what sometimes people try to have a false economy, if you will, when they go into, I guess, those options.
So how do you know if you're referring to a good sleep specialist? Because we have dental hygienists on from all over. So what if they're not from Ontario and they're from Alberta, or where would they look for this?
Well, are you talking about dental or are you talking about?
Yeah, because we have somebody who's here saying that she's from Alberta, and where can patients search for credible dentists that
Oh, there's
testify?
some amazing
Alberta.
dentists in Alberta
Alberta,
that are involved in dental sleep medicine. And it's, you know, first of all, one good resource is American Academy of Dental Sleep Medicine. So AADSM.org, right, has a find a dentist, you know, part of the website, and you can go there and you can find qualified dentists. You can find dentists that are diplomats of the American Board of Dental Sleep Medicine. And then, you know, of course, if you're in any particular jurisdiction and you're having trouble finding somebody, that, you know, just email me. I'd be happy to give you a couple of options for people that I know of out that way.
So it's AADSM.org.
Correct.
Okay. I'll put that in my follow-up email as well. Thank you for that. Mhm.
Don't be afraid, reach out. We're very approachable and friendly.
Perfect. Maybe we'll put their contact information in that after email as well, Kathleen.
Mm.
Perfect.
I put it in the other one too, yesterday's email.
Oh, fantastic.
Hmm.
Lots of questions, and I don't know if you can answer this easily, but I know from being in your clinic, there's lots of different types of appliances that I saw there. So for those asking for a cost, is there a way to give an average cost of these appliances or no?
Well, I mean, you know, every clinic is going to be dealing with this differently, and because there is no, you know, set fee. So there's going to be a range if you look, and it depends where you are, also which province you're in. You know, there's going to be a range in what the fee is and how it's handled as well. In my clinic, I have a global fee that includes the appliance and all of the necessary appointments, including home sleep testing of some kind, whether we do it once or 5 times in order to optimally calibrate the appliance, and including the 6-month follow-up appointment with them. So it's a global fee that includes all of that, and it's a set amount. And I don't differentiate from appliance to appliance. I have one global fee, and we pick the most appropriate appliance for them. And this way, they're not sort of picking or thinking about going for an appliance at less optimum for them because it might be $200 less, you know, because there is a variance from one appliance to the other in lab cost. But I sort of like average it out, and I try to make it as painless as possible, thinking wise, for the patient, right? And I don't want them to think economically about something to do with their health. So that's why it's one fee that covers off whichever appliance you need.
I like that.
Along with the tasks and the titrations and all the appointments following up.
How do you suggest they clean these appliances? Because I have seen some appliances that have come into my practice as they're bringing them in. I like to sort of just see them, and some of them look a little worse for wear. So what suggestions can you give us to offer for our patients and our clients to clean them?
Sure. Well, first of all, any denture cleaner, you know, will do the job, just like, you know, keeping their dentures clean. However, what you do have to keep in mind is that each appliance is made of different materials. And so for some appliances, you don't want to be soaking them all day long. And for other appliances, it's okay to do that. And then there are certain products that I like to use for the nylon appliances because they do a fantastic job at keeping them clean, white, looking just like the day I gave it to them, even years into it. However, I wouldn't use that particular product on an acrylic appliance with a soft liner, right? Because it would just, you know, erode away at that. It'll shorten its lifespan. So every appliance, there's a specific set of information that you're giving the patient is particular to that appliance. So there's no generic, you know, but, you know, it's a matter of keeping them disinfected. And sometimes for certain appliances, the only thing I recommend is soaking in some water and a couple of drops of Palmolive dish soap, you know, on the weekend. for about 30, 40 minutes, because I know anything more than that is going to shorten that particular lifespan for that particular appliance, right? So it's very appliance specific. So every manufacturer is going to have their recommendations because they'll know what is best for their appliance.
So just looking back at that that word, I'm trying to say it. Okay, I'm
Ew.
very tired. Sorry, the hue, and just helping your client find that information based on their appliance if they haven't received it from a specialist, just to help them keep it clean. Thank you very much.
Right.
So there's a lot of questions, Beth. Once we're done, is there a way that we can just export them into an Excel sheet? Like, can we keep them? And I'm thinking either, because they all want to kind of know the answers to all the questions. So I'm wondering, do I hop online with Dr. Viviano one day and just do a quick video and ask him the questions to get that answer? And then we put it on our YouTube channel.
Yes, I can give you a copy of the questions for sure. And that's probably the best way, because yes, there are probably 20, 25 outstanding questions.
Wow.
So unless you want to do, like, I think talking is always easier than typing. So what do you think, Dr. Viviano?
I liked your idea. I'd be
Okay.
happy to do that with you
Let's
sometime.
do it.
Okay, I think that's made a lot of people very happy. So I will get that list off to Kathleen, and then I'll leave it between you and Dr. Viviano to arrange a session, a Q&A from the
Yeah.
audience session. That would be fabulous. Kathleen, we also have additional information for sleep apnea. Do you want to just talk a little bit about what's available?
Yes, through RDHU, we have the bundles. If you go to RDHU's on the shopping cart, you go down to bundle, and you'll see some courses that Dr. Viviano did for us, as well as one that I did. So that's in there. Also, with Dr. Viviano's website, there's a whole lot of information. You've got resources that you can, for the professional, also for the patient, and lots of courses as well. So what I'll do is I'll send direct links in the follow-up email. So if you're not part of the RDHU world and you're on Facebook, then I would encourage you to go to rdhu.ca and opt in. Otherwise, we have everybody who's on Zoom, and we can add it to our group for today, and then I can send the follow-up to everybody with the link to the quiz, so you get your certificate as well. Does that sound good?
That's perfect.
Will you also include in there the new article that you just wrote that was published? As
Yes.
well?
And thank you. And I also included it in the email yesterday as well. So if you are part of RDHU, you would have got a link to the bundle, a link to Dr. Viviano's website, a link to the article. And for those of you who are maintaining a portfolio, those are all great added resources, as well as today. This is a 1 hour activity that you can use along with the other information. Yeah. I know when I had my goal last year, it was on sleep apnea, 2019. And I had I think 22 hours of research that I did. And so those are all really great resources. There's so much studies and everything. And I use that for my goal. And then I created the presentation. I shared it with Dr. Viviano. He gave me a thumbs up. So that gave me the confidence to go and present it live and just to bring awareness to that. So it is a great goal, and then a great thing to implement. How did you make changes to your practice? I included the questionnaire. These are the questions that I ask. I now refer to the GP. We put a office protocol in place. I follow up with my clients after they've been diagnosed to make sure that they are wearing their appliances. So that's all number 4 of our learning portfolio. You've done your learning. Now, how did you apply it to your practice to make your practice to enhance and improve client care? Yeah.
So if I could say something here, you've done a wonderful job with everything that you've done since you've gotten passionately involved in this. And the model that I hold up when I'm speaking to dentists is the way they should be dealing with this is exactly the hygiene soft tissue management model that you folks do. Basically, screening, documenting, following up, have a plan of action for that patient, and then checking them again the next time they come in, following through with them, following through with your recommendation. Exactly the process you go through with your periodontal therapy, right, is the way we have to think about it with sleep disordered breathing. It's almost like it's a sleep disorders dentistry program is like another version of a soft tissue management program, where you can then, once you earmark somebody as having an airway issue, right, you're continuously following up with them, just like you said. And that's like music to my ears, because that's what every dental office should be doing out there. You know, when you think about the number of undiagnosed people, 85–90% of severe sleep apnea is undiagnosed, you know, walking around in our country. Can you imagine if the entire dental workforce was mobilized and routinely screening all their patients? In 3–4 years, that would change dramatically, right? So that's how impactful, you know, dentistry and hygiene in particular can be, because you folks spend so much time with your patients and you get to know them so well and you have good relationships, right? So
it's life changing. Like, honestly, since I've started the treatment, I feel like my old self again. And I didn't realize that. I thought I was just feeling the way I was because I was busy. But and my husband says, like, your eyes are shining every morning. Like, he's like, it's so nice to see. Like, I'm back to, I wake up, I feel great. You know, it's such a huge thing. So I'm very thankful to have been diagnosed and to be, you know, treated, and I'll continue that. Yeah. So this is also, we want to, before we sign off, we have, we had a contest last month for April Oral Health Month. And so we have people that had converted their clients from a manual brush to a power brush. And, you know, there's studies, like, I won't get into it now, but there was studies showing the effect that periodontitis has when you have a COVID patient. And then there was studies on the effect we have when we convert our patients from, you know, manual, if they're manual with sodium fluoride versus just power, or power and stannous. It's like 20% can get healthy if they're just doing the manual brush, 80% if they're just doing the power brush, but it's 100% for clients that have gingivitis if they're on stannous and power. So we ran a, you know, hashtag manual to power challenge. And so now I'm going to pick, there's five brushes going. And so for every person that converted a client, they get an extra thing in here. So I've got Andrea Smith, Gina Lewis. There's a lot. Oh my gosh, Gina Lewis, you were busy, girl. Hang on, you just try and switch it up. And then Andrea Smith. Oh my goodness. I was busy folding all those today. So there we have it. And I don't know if they're on live or not, but if you're on, send a little chat. So I'll have to get in touch with you guys. That's awesome. But yeah, for every patient they converted, they got a ballot. So there you go. They've been busy. So that's fun. So they get the new IO power brush, which is a, there's Gina.
Oh, good.
I think you won how many? 1, 2, 3. That's awesome. And then Andrew Smith got 2. That's great. All right, ladies, it's awesome. You're lucky. So those are wonderful brushes. So you'll be very, very happy when you receive them. And thank you to everybody for being on with us today, and to the cast of the RDHU, and to our wonderful guests. Thank you for sharing your knowledge and your passion with us, and have a great Mother's Day. And Louise, you have something you wanted to share for Mother's Day.
Yeah, I do. I would like to wish everyone who's a mom out there happy Mother's Day. I like us to think about the moms that are currently nursing and providing care to the many patients that are in the hospitals right now with COVID. And I'd like you to also think about the moms of the grown-ups of those their grown-up children. Like my eldest is currently nursing in the ICU at St. Joe's in Hamilton. So just to give a think about all of those moms out there, and first responding staff that are, putting aside their Mother's Day and thinking about them this weekend, because we are very grateful for all of their help and service. So happy Mother's Day to you. And if you have a grown-up who is also serving our community to keep everyone healthy, God bless you too.
Thank you.
Thank you. Thank you for having us.
Oh, my pleasure. And Kathleen and Beth and Carrie and I are thrilled that you were able to come and share your knowledge with us today.
Yeah, it was good to see you.
And I look forward to the answers of all those questions. That'll be a follow-up. So
I'll be in touch, Dr. Viviano.
we've had a few
It'll be a
people in the
pleasure.
chat already say
All right. Thank you so much.
Yeah.
Thank
Okay.
you. Bye.
Bye.
Bye.